Hello, everybody, and welcome to the diabetes management and monitoring activity or lesson within the Nursing 4634 Practicum course. This lecture or short lecture will be about diabetes management and monitoring and how we do that, a little bit of information about hyperglycemia, hypoglycemia, carbohydrate counting, and so on. So we're going to go ahead and get started here. So here's what we're going to touch on today. We're going to touch on the 4 different types of insulin available to us. We're going to talk about how to calculate carbohydrate counting. We're going to talk a little bit about the interpretation of insulin orders. We're going to discuss and identify interventions for managing hypoglycemia and hyperglycemia. And then we're going to identify some key safety and quality concerns related to diabetes management. So why is it so important that we need to be concerned about diabetes? Registered nurses need to be aware of the different warning signs and symptoms of both hyperglycemia and hypoglycemia in order to identify each. There are specific signs and symptoms that are attributed to each hyper and hypoglycemia that make it relatively easy to identify each condition. Furthermore, people with diabetes are at higher risk for other problems, such as infections, sensory perception deficiencies, and nutritional imbalances. Nurses can play a key role here by identifying these problems early and provided the needed care so that the conditions or the other comorbidities that are associated with diabetes can be treated and taken care of early on so that they don't get worse. And so because of that, nurses really are in a unique position to support people with diabetes. And one of the biggest things that nurses do is provide education and tools to understand medications, nutrition, and various activities that can promote the good care of the person with diabetes. We remember that nursing is, a large majority, I would say 75% of what nurses do is educate. And one of the big things that we see, especially in the ambulatory setting, but also in the acute setting as well, is how to manage diabetes mellitus so that we prevent or curtail the other comorbidities that that come about because of it. So we're going to start with some insulin, okay? But before we start talking about the different kinds of insulin, it's really important that we understand 3 important terms regarding that insulin. And the 3 terms are listed on the slide here: onset, peak, and duration, okay? So when we think about onset, we're talking about the length of time before insulin reaches the bloodstream and begins lowering blood pressure or blood sugar, okay? And so if you want to think about the period of time it takes from immediately when you stick your patient with the needle in the belly, right, to the time the insulin reaches the bloodstream, because remember that insulin needs to make its way through that adipose tissue. It might need to make its way through some muscle before it gets to the bloodstream. All of that time, the transit time, let's call it, is the onset, okay? The peak then is the time during which insulin is at its maximum strength in terms of lowering blood sugar. So it's the time at which the medication is at its strongest. And this is going to vary depending on the insulin that we're dealing with. So then finally, the duration The duration refers to how long the insulin continues to lower blood glucose. Okay, so it's in the bloodstream, it's lowering blood glucose. How much time or how long does that insulin continue to work? Okay, so I want you to think about, as you're watching this lecture, we've talked about what each of these definitions are, but I want you to think about why it's important for you to know them. And what are the nursing implications for knowing these terms? Okay, I want you to think about that. So then we're going to move into the different types of insulin. There are 4 different types of insulin that are commonly seen in the healthcare setting. There's rapid acting, there's regular / short acting, intermediate acting, and long acting. Okay, I would say that the most common of these that you're going to see is probably the rapid acting and the long acting. Okay, if you work in a critical care setting, you may also deal with regular insulin as well. So I want to draw your attention to the little nugget post-it note that's up in the right-hand corner here. And this might be important to know for your quiz later on, is that regular insulin is the only type of insulin that can be given intravenously. Okay, so that's important to know. And usually in most healthcare settings, because insulin is a high-risk medication and requires lots of monitoring, usually if someone is going to be on an insulin drip, they're going to be in some sort of ICU setting. Okay, so let's go back and talk a little bit about rapid acting. It's rapid because it starts quick. The onset is really fast. Within just a few minutes, 3 to 15 minutes, depending on the person, is when this insulin is going to start working. The peak is an hour. So this insulin is going to be at its peak strength for 1 hour, and it's going to last then for 2 to 4 hours. Some different types of insulin that you might see out there, or some different names of insulin that might fall under this type, are insulin aspart or Novolog, insulin glulicine, and that is Apidra, and then insulin Lispro, which is Humalog. Moving on, then, the regular and short-acting insulin, you can see that it stretches out the onset and the peak and the duration just a little bit longer. Okay, the onset is 30 minutes, peak is 2 to 3 hours, but the duration of the insulin effects are going to last 3 to 6 hours. Okay, and so human regular insulin is going to be the kind, and so you might see Humulin R, you might see Novolin R, you might see Velocilin R. That R means regular, right? Okay. The next is going to be an intermediate acting insulin. And so this is kind of the middle, if you will, of the onset, peak, and duration. The onset is a bit longer, 2 to 4 hours. Peak is 4 to 12 hours. Duration could be, a half a day or longer, 12 to 18 hours. Okay. And this is your NPH insulin. And when you go into your insulin administration activity in lab, you will learn about this, and you will also learn how to mix this insulin with regular insulin so that it maximizes or can extend the onset, peak, and duration of either the regular insulin, or it can also act to, in a way, decrease the onset, peak, and duration of the intermediate acting insulin. So basically, if you mix those two together, you're kind of pulling the best of both worlds. You're affecting the onset, peak, and duration of both of those medications, and how much you affect the onset, peak, and duration of either the intermediate acting or the regular short acting depends on the ratio of each insulin. So if you've got more intermediate acting than regular short acting insulin, there's going to be an effect there. If there is more regular short acting insulin than intermediate acting insulin in that ratio, there's going to be a different effect there. So be thinking about this while you're working through this lecture, about how the ratios of each insulin is going to affect the onset, peak, and duration of each type. Okay. And then finally, long-acting insulin. This onset is going to take hours, 1 to 2 hours. There really is no peak. I will show you what that looks like in a visual here on the next slide. The duration is up to a day, 24 hours. The type of insulin, or I'm sorry, the names of insulin within this type could be insulin detamere, which is also known as levemir, or insulin glargine, which is also known as Basaglar or Lantus. Okay. And so one key thing to remember with the long-acting insulin is long-acting insulin is prescribed as a standing order, or as a set dose, a fixed dose. And I'm going to talk a little bit about fixed dose insulin here in just a little bit. But what fixed dose insulin means is that you will give this insulin to the patient no matter what their blood sugar is. If their blood sugar is really high, you will give this insulin to them at the prescribed dose. If their blood sugar is really low and they're hypoglycemic, you would still give this insulin to the patient, that prescribed dose. And I'll tell you why here in just a little bit. Okay. So I want to show you just a little visual of how all of this looks. So if you take the red ink here, this is a demonstration of rapid acting insulin, and you can see that it just takes minutes to start to work. Okay. And then the peak time, now these times are a little bit different than the last time I showed you, but the ballpark is the same. It peaks for 30 to 90 minutes, and then it drops off right away. Okay. And you can see with the regular short-acting insulin, it's a little bit longer, but there still is a definite peak. You can see with the intermediate-acting insulin, it's a little bit longer yet, but there's still a definite peak. But when you look here at the long-acting insulin, it's really stretched out over the course of the entire day, and there really is no peak. It's just kind of a hump here, right? There really is no definite peak. And this is why we can give long-acting insulin even to somebody who is actively hypoglycemic, because there is no peak, and it takes so long for that insulin to start working, and it takes, and the duration of it is so long, so that even when you correct somebody's hypoglycemia, they're still going to need this medication. And typically correcting hypoglycemia is a matter of minutes. Okay. And so even if you give this medication to someone who is hypoglycemic, you will have the hypoglycemia fixed before this insulin even hits the bloodstream. So that's why it's okay to give it. And it is a fixed dose insulin, so it is meant to be given no matter what the blood sugar is on the patient. Now, if you've got somebody who is really having trouble with managing their blood sugar, and they're always, day after day, maybe they're in the hospital for a week, and for 2 or 3 days, their blood sugar is just always abnormally high, there might be a conversation with the provider to up the fixed dose of that bedtime insulin to try to help that, okay? But that still doesn't negate the fact that you would give this even in the presence of hypoglycemia with a patient. All right, so let's talk a little bit about fixed dose insulin. So with this method, individuals will take a certain set amount of insulin. In this slide, the example is with each meal. So for example, an individual might take 6 units at breakfast and 8 units at dinner. And that is for certain, hard and fast. There's no blood sugar testing. There's no carb counting. It just, they take 6 units at breakfast, 8 units at dinner. That's it. Another example of this is bedtime glargine. So a patient might be prescribed 24 units or 30 units or 40 units. I've had patients up to 80 units of glargine at bedtime. And no matter what their blood sugar is, they're always going to take that 24, 30, 60, 80 units at bedtime. Because remember, we have to think back to the onset, peak, and duration, and that is what's going to make that okay, right? So the numbers don't change based on blood sugar readings or the amount of food eaten, all right? But now we're going to talk about something that's a little bit different and something that you may have seen in a clinical setting or perhaps in a setting that you've worked in, and that is sliding scale insulin, okay? So in most sliding scale insulin therapy regimens, blood sugar is taken using a glucometer, okay? This is typically done 4 times a day, usually before breakfast, before lunch, before dinner, and then before bedtime. That order, of course, can vary depending on the provider and depending on the patient, but it is pretty common to see a Q4 4 times a day. The amount of insulin is then administered is based on the blood sugar measurement. Okay, and so before these meals, we have to do this blood sugar reading before the meals because the minute a food substance touches the tongue of a patient, they're already absorbing that sugar and you're going to have a false reading, right? You're going to have an abnormally high reading. And so in the case that you made a mistake and you let the patient eat before you took your blood sugar or their blood sugar, you would need to wait at least 3 hours before you could get a reliable blood sugar reading on that patient. But so this is done before meals. And so usually in the morning, lab comes at about 6 o'clock. That's usually when nurses will come and do blood sugar readings. Sometimes nurses will wait till 7 where it's closer to breakfast time. But usually when patients get up in the morning, that's one of the first things is the nursing assistant or the RN or the LPN will go around and collect blood sugars to see if any preprandial means meal, pre-meal insulin is going to be due. Okay, and the same thing is true with lunch and dinner, and then again at bedtime. And usually bedtime for patients is considered to be about 8 o'clock or so. In most cases, this is going to be your rapid acting insulin. So it's going to be your blue pen with an orange top. This is your insulin aspart, which is one of the most common that is used for sliding scale correction. Okay. Another name for sliding scale insulin is also called correctional insulin because we are correcting the blood sugar based on the glucometer reading. This is different from carb coverage insulin that I'm going to talk about in a little bit. So you can kind of associate sliding scale insulin with correctional insulin. All right. So let's talk a little bit about rounding insulin. We know that insulin pens, they kind of look like this. what is, I want you to think to yourself, what are the rules regarding the rounding of insulin? Okay, can insulin be rounded up to the nearest unit, right? If a person does the math, if a person does some carb coverage and figures the math out that we'll talk about here in a little bit, and the math says that this person needs 6.5 units of insulin, do we give 6.5 units of insulin, or do we give 7 units of insulin because we're rounding up because of that extra 0.5? The answer is no. We never, ever, ever round up insulin. Okay? You can, when you're doing your carb coverage math, you can round on your carb coverage math, figuring out how many carbohydrates a patient has eaten. You can round with that, but you cannot ever round your insulin dose, because we always want our patient a little sweeter than not sweet enough. Okay. Another thing to remember is you can only give full units of insulin, right? Pediatrics have the ability to give half units, but that is a very specialized population. Okay. Other than that, we only give whole units of insulin, and we always round down. If anything, we always round down. All right. So we've got all of these different orders that we've talked about. We've talked about correctional scale, or that sliding scale. We're going to talk about carb counting, right? What does all of this stuff mean? So we've talked about the correction piece. Now we're going to talk about the carb coverage piece. So actually, I'm going to back up a little bit. We're going to talk first about how to read a sliding scale. Okay. So first, on your order set, there's going to be a sliding scale that looks very similar to what is on the screen here. There's going to be ranges of blood sugar, and then there is going to be the corresponding insulin dose. So to start with, you need to take a blood glucose reading. Okay. And then you need to match that blood glucose reading to the value in the left-hand column of the chart. And then you need to give the dose that matches that value. All right. So, for example, you take a patient's blood glucose before lunch and it is 234. Your order is to give Novolog insulin subcutaneous before meals 3 times daily and at bedtime based on this sliding scale. At a blood sugar of 234, how much insulin should you administer to the patient? So we've got 234 as our reading. We're going to go over here to this left-hand column, and we're going to look at where the range is. Looks like it's right here, 201 to 250. We're going to go across. The patient needs 4 units of this insulin. Okay. There we go. 4 units of insulin. And so that same principle applies to any sliding scale that you will have been given. Now, providers have the license to be able to adjust this sliding scale if they feel it's not meeting the patient's needs. So if your patient is really insulin resistant or the diabetes is not being managed very well, the provider can go in and they can tighten up this sliding scale so that maybe we start giving insulin when their blood sugar hits 120 instead of 151. So this has got some flexibility, and really this is a conversation between you as the registered nurse and the provider, right? This is where your advocacy, your critical thinking, your clinical judgment come into play to be able to look back at the record and say, you know, for the last 2 or 3 or 4 shifts, this guy's blood sugar has just been really high, no matter what the insulin we're giving him. So then going to the provider and saying, hey, for the last 3 shifts, you know, we've been giving 6 units of insulin at every single meal. Is there any chance that we can tighten up this sliding scale a little bit? And oftentimes providers will have no problem doing that. Okay. All right. So now we're going to talk about carbohydrate counting. So what the heck is carbohydrate counting? So it kind of is what it sounds like. It's counting the carbs that a patient has consumed after a meal. So the first bullet, this is done after meals have been consumed. So in contrast to sliding scale insulin, which is done before a meal has been consumed, this is done after a meal has been consumed. And the amount of insulin then is based on the number of carbohydrates that the patient consumed. So then the question can be asked, what do you do if there's both correction scale and carbohydrate insulin ordered? So think about that for a second. If they have pre-prandial insulin, sliding scale, and they've got post-prandial insulin, carb coverage, what do you do if they have both? So if a patient is to have both pre-prandial or correction and post-prandial carbohydrate counting, oftentimes nurses will combine the 2 doses in 1 injection after the meal. Given the caveat to that is it has to be the same insulin, and oftentimes it is. And nurses do this because nurses like to cluster cares. You go in there and you bug the patient fewer times, and you get to prevent an additional injection, an additional needle stick. So, you know, by the book, these should be done separately. They must always be done separately if 2 separate insulins are being used. But it is common practice that if the same insulin is being used for preprandial and postprandial insulin, that you can combine those 2 after the meal and give them after the meal. Okay. So that's the answer to that question. So which foods contain carbohydrates? And of course, this is not an exhaustive list, but hopefully you can draw a little bit on your nutrition prerequisite that you had to take to get into the program. We know that grains contain carbohydrates: breads, noodles, pastas, crackers, cereals, rice. We know that fruits, you know, healthy fruits, apples, bananas, berries, mangoes, melons, oranges, they contain carbohydrates. Legumes or beans, or I don't even know what legumes really means, but it's beans and seed-like, pod-like foods like beans, lentils, and peas. And of course, anything that's snacky and has sugar in it. So cakes, cookies, candies, other desserts, okay? Drinks. So this could include fruit juices, other kinds of juices, soft drinks, fruit drinks, sports drinks, energy drinks, and then vegetables, especially anything starchy that's got, that's got a high starch content, such as potatoes, corn, and peas. They have a high carbohydrate value. Okay. Now we're not going to go into the detail of complex carbohydrate and simple carbs, because that really doesn't matter when it comes to overall carb coverage. The important thing is to know what foods are going to be high in carbs and to look out for. And so I'm going to show you a label here, and the nutrition label is going to give you some really valuable information. So first of all, it's going to give you the serving size. So if you look up at the top of the label, it's going to say serving size 1 cup. So that means that that every piece of information then on that label is going to be relative to the serving size, relative to 1 cup of this particular food, which happens to be macaroni and cheese. Okay. And so the total grams of carbohydrate is going to be 31 grams. Now you can see that it's further broken down into how many of those carbohydrates are dietary fiber, how many of those carbohydrates are sugar. But again, we're only focused on the total carbohydrates. So those breakdown, the breakdown really doesn't matter so much. Okay. So the American Diabetes Association recommends that 50 to 60% of calories from carbohydrates, recommends 50 to 60% of calories come from carbohydrate, 20 to 30% from fat, and the remaining 10 to 20% from protein for levels of caloric intake. So let's do some practicing on our carb counting, shall we? So I'm going to present you with a few trays, and we're just going to kind of count up the carbs that the patient consumed. And this is pretty realistic because if you have a patient who is on a diabetic diet, there's going to be a receipt that comes with the meal that lists everything that is on the tray and how many carbs they are, right? And then when the patient is done eating, it is your job then to go and count how many carbs the patient ate relative to that receipt and what's left on the tray. Oftentimes, this is a registered nurse responsibility. Some hospitals will even have little magnets that you put on the outside of a patient who has diabetes on the outside of their room that says RN to remove tray. And this is the reason why, because some hospitals believe that this part is out of a nursing assistant's scope, or maybe even out of an RN or an LPN's scope. And so they want the RN to do this task. So let's look at a tray. Okay. So you have a tray here, and it looks like there's the food that's on the tray and how many carbohydrates they are. And the patient ate 100% of the meal. So take a second and count up how many carbohydrates you think the patient ate. Okay, so hopefully you came up with about 97 carbs. 97 carbs. And 97 seems high, and especially if we're thinking in terms of how much insulin we're going to have to administer this patient. We would never administer 97 units of insulin, but I'm going to introduce you to something called an insulin factor or a carb factor here in just a little bit that will help to break this number down just a little bit farther. So 97 carbohydrates on this tray. Let's try another one. Okay, work through that one a little bit. Looks pretty tasty to me. All right, so hopefully you came up with 77.6, right? Because we had some weird math in there. We had 2/3 of the milk was gone and a half of the roll was gone. So that's going to break this up a little bit. But 77.6, now remember what I said before, it is okay to round carbohydrate numbers. So 77.6, you can round this to 78 carbohydrates. That is fine. What cannot be rounded is the insulin that will come later. Okay. Let's try another one. So you've got the meal tray slip right there, and then you've got what the patient ate. How many carbohydrates did they consume? Go ahead and give it a whirl. Okay, so hopefully you came up with about 77 carbohydrates. 77 carbohydrates. Okay, let's move on to the next example. Here you've got a meal tray slip, and then you've got some information about what the patient ate. How many carbohydrates did they consume? All right. So hopefully you came up with about 66 or 65.5 carbohydrates. Remember our rounding rule. We can round up on the carbohydrates. So this would be 66 carbohydrates. All right, let's go to the next one. Last example. You have a meal tray slip. So we got a good old-fashioned school lunch here. How many carbohydrates did the patient consume? All right. You should have ended up with something like 91.6, which we can round up to 92 carbohydrates. So then let's talk about how we get from number of carbohydrates to how much insulin the patient requires. This is something called the carbohydrate to insulin ratio. Now, these ratios can vary depending on the time of the day, depending on the provider, and depending on the patient. So in this method, you give units of insulin per the amount of carbohydrate consumed. And again, this is going to vary depending on the day, the time of day, and the client. And so let's give an example here. So calculate all insulin dose for food. You add up the number of grams of carbohydrate in the food that you will eat. So we did that, those 5 trays, we added up all of the carbohydrate, right? And then we divide by the total number of carbs by that carb to insulin ratio. I'm going to tell you right now that the most common carbohydrate insulin to carb ratio is going to be 15. And this is actually referred to in some settings as a carb choice. So 15 grams of carbohydrate is known as a carb choice. And some hospitals will actually label, they will do the math for you. They will convert the total carbohydrate, divide it by 15, and give you the carb choice so that this math is already done for you and you know exactly how much insulin to give your patient based on that receipt. But here, we want to teach you how to do this longhand just in case your facility doesn't offer this. So we take the total grams of carbohydrate that was eaten. We divide that by that insulin to carb ratio, which is most commonly 15. So in this example, the patient ate 45 grams of carbohydrate. We divide that by 15. The patient is going to get 3 units of insulin. Okay, 3 units of insulin. And you can do this. Let's play with a decimal a little bit, and work the math around. So let's say you have someone who ate 47 grams of carbohydrate, and we're going to divide that by that 15. That's going to give us 3.13333. How much insulin are you going to give that patient? We're still going to give that patient 3 units of insulin, because we always round down, right? We always round down. So let's go the other way around. Let's pretend this patient ate 55 grams of carbohydrate. We take that 55 grams of carbohydrate, we divide it by 15, and that's going to give us 3.66666. So in the normal math world, we would want to round up, right? We would round up to 4, to the nearest whole unit. But remember, we're dealing with insulin. We cannot round up. We want to keep our patients a little bit sweeter. So we're going to round down to the nearest whole unit. So this is still going to be 3 units of insulin. Okay, 3 units of insulin. All right. So hopefully that makes sense. If you want to, repeat this section of the video or pause it and do some of your own math problems, that's fine. But hopefully this gives you a good idea of what I'm getting at here. So a couple more things before we wrap up. Let's talk a little bit about hyperglycemia versus hypoglycemia. Okay. So hyperglycemia, typically in the hospital setting, hospitals have a little bit more flexibility than outside of the hospital, because hospitals have the ability to control. They've got a lot of control with therapeutics and pharmacology and things like that, that they can manage diabetes and manage blood sugars really quickly. So in the hospital setting, really anything above 160 is considered pretty hyperglycemic. You may have read in your book that 80 to 100 is kind of the normal range. Anything over 100 is considered hyperglycemic. And yes, I would say in the home setting, that's probably pretty true. In the hospital setting, there is a little bit more flexibility just because there's more control. Okay. Hypoglycemia, on the other hand, is, anything less than 80 is still considered to be, and some hospital policies will even say anything less than 60 is hypoglycemia. So a lot of this is really facility dependent. Okay. So remember that hyperglycemia is the technical term for high blood sugar, and can happen when blood sugar levels rise above the 180 mark in this demonstration. Hypoglycemia is the technical term for low blood sugar, and can happen when the blood sugar level falls below 80 in this demonstration. Okay. All right. So low blood sugar can be caused by a bunch of different things. All right. Can be caused, if a person has diabetes, oftentimes low blood sugar is caused by too much insulin. Somebody did the math wrong and they give themselves too much insulin. Or maybe they're a type 2 diabetic and they gave themselves too much oral medication. Okay. If somebody doesn't have diabetes, low blood sugar can be caused by not eating enough, or demanding more out of their body without refueling their body. There are certain medications that can cause the loss of blood sugar. Alcohol can cause a low blood sugar. There are various underlying conditions as well. as well as reactive conditions. Okay, so symptoms that patients will experience include hunger, fatigue, shaking, sweating, pale skin, dizziness. And if that is not corrected pretty timely, that is going to advance then into confusion, slurred speech, blurred vision, fainting, seizures, and could result in a coma, right? Typically, when it comes to correcting low blood sugar, there is a 15-15 rule. So we'll take someone's blood glucose. If it's lower than policy, so let's say it's lower than 60, it's 55, right? We're going to give them 15 grams of a fast-acting carb. Usually these are simple carbs, carbs that break down and fuel really quickly, something like a candy bar or a soda, right? Then we're going to wait 15 minutes. So that's your 15 and 15. We're going to wait 15 minutes, and then we're going to test again, right? And we're going to do this over and over again until the patient's blood sugar is either above 70 or whatever the hospital policy is for you. Okay. There is a drug out there called glucagon, and glucagon is an intramuscular injection. So say, for instance, your patient has a very low blood sugar and they are symptomatic, so they don't have a very good gag reflex. You wouldn't feel safe giving them any food. And let's just up the ante and say they don't have an IV access, right? Or they pulled their access out. This is another way to be able to get to correct that low blood sugar quickly. It's not going to be as fast as an IV correction, but it's going to be faster than an oral correction, and that's called glucagon. Hyperglycemia, on the other end of the spectrum. Some causes are too much food, too little insulin, or too little of the patient's type 2 diabetes meds. Illness can cause abnormal high blood sugar, as well as stress can cause abnormal high blood sugar. It is not uncommon for patients to come into the hospital and they are not diabetic at all. They come into the hospital and they end up on insulin because of it's reactive, right? It's a stress reaction to being in the hospital, and that causes blood sugar to go up. Infection is a big one. Steroid use, prednisone, and the like, causes blood sugar to increase. Okay. It often starts slowly, but if it's not treated right away, can lead to medical emergencies. And we'll talk about one of those here in a second. But people with really high blood sugar, they need to pee a lot, right? They have extreme thirst, and they're hungry. And so remember the 3 P's here. Polydipsia is extreme thirst. Polyuria is the need to urinate often. And then polyphagia is always being hungry. Dry skin, that is a result of dehydration, because remember, water follows sugar. And if there's a lot of sugar in the blood, it's going to pull water from everywhere, including your skin. And that's going to cause dry, itchy skin. It's also going to cause blurred vision and drowsiness. These are neurological side effects. So remember, the blood is locked inside the vasculature. It's not getting inside the cells. It's not getting to the brain where it's needed. And so even though we've got all of this sugar, it's not being used. It's not feeding the body, and the body is essentially starving, which is what we're going to be talking about in the next slide. Okay. And then slow healing wounds. High blood sugar, high blood glucose has an inhibitive factor on white blood cells and the restorative pieces of our blood that causes us to heal, and so it can cause slow healing wounds. So an example of an extreme case of high blood sugar is something called diabetic ketoacidosis. And so this is a result of severe insulin deficiency, and it's a common complication in type 1 diabetics. Typically, this is the sentinel event that, that sends a kid, a small juvenile, you know, less than 10 years old, sends them to the emergency room, and this is how they find out that they have type 1 diabetes. Is it, you know, it's gone on undetected for a few years, and then all of a sudden the kid is playing on the playground and they fall over, and they go to the emergency room and they draw blood and they find out that their blood sugar is like 800. It's type 1 diabetes. This is usually, or one of the common sentinel events that is an indicator for first-time diabetics for kids. But it is characterized by hyperglycemia, which is high blood sugar. Anytime where there's a high sugar content, we're going to have some acidosis. We're going to have some metabolic acidosis. There is so much sugar that the kidneys cannot filter it all out. And so you're going to have glucoseuria, which is blood in the pee, right? And then we're also going to have, the beginning of breakdown of ketones, or the breakdown of fat, okay? And the byproduct of the breakdown of fat is ketones. And so we're going to start to see ketones in the urine too, because the kidneys can't filter it out, and it's going to end up in the pee. And it's spilling over. The kidneys can't keep up with filtering it out. And so it's going to spill over along with the glucose, and you're going to have ketones in the pee, right? And this is a result of the body is starving here. There's, like I said before, there's so much sugar in the bloodstream at this point. It's not getting where it needs to go. The body is freaking out. It's starving, and it's going to start eating anything that it can to stay alive. So it's going to start to break down fat. Okay. And that's what's going to cause your ketonemia, and eventually your ketonuria. Now, this is corrected. Oftentimes these patients, they go into the ER, they get started on an insulin drip, and they end up in the ICU for a few days to get corrected. And then usually endocrinology gets involved, and they start the patient on insulin, and then they start their diabetes journey. Kind of a key sign of this condition is something that we call like a fruity breath smell. And so when people break down ketones, one of the byproducts of that is people have a fruity smelling breath. And so when you go up to somebody and they're collapsed on the floor, they're unresponsive, but they're breathing, if you feel safe doing so, put your nose up by their mouth. I know it sounds weird, but you know, we're nurses, we're resourceful, we use all the resources we have, and some of our most valuable resources are our senses. So put your nose up by their mouth, and if their mouth smells like they just ate a Jolly Rancher, it could be that they've got diabetic ketoacidosis and they need to get to the hospital immediately. Okay. So risk factors are going to include inadequate insulin administration, concurrent infection or illness, and any sort of trauma or injury that the body might be reacting to. Okay, so that is this little lecture on diabetes management and monitoring. When you're done with this lecture, please go ahead and complete the quiz, the diabetes monitoring and management quiz in Brightspace. That needs to be done before lab. There are 10 questions on that quiz. Those questions are going to be related to the content that's in this lecture, as well as your preparatory work for lab, okay? There are 10 questions. It's open book, open note. There are no time limit, so take your time. You can come and go as you please. The recommended resource is ATI. And because there's a lot of leniency with this quiz, being open book, open note, no time limit, I've provided you with the resource. The questions will stand the way they are. There's no arguing for points. There's no challenging of questions. Just like the NCLEX, the questions are what they are. If you get questions wrong, then we learn from that. Okay, so it's a 5-point quiz. It's not going to make or break you. Each question is a half a point apiece. So go ahead and do that. Please refer back to this lecture and your other resources as necessary, and we will see you in lab. Have a great day.